يلا start حبيبي.
بسم الله الرحمن الرحيم. Welcome everyone in this new meeting of Egyptian Society Nephrology and Transplantation CME chapter meetings. And today we are indeed with one of the hemodialysis meetings by the great hemodialysis scientist of Egypt, Professor Hesham Elsayed. And before I introduce Professor Hesham, I am to introduce and welcome our great moderator today, Professor Walid Masoud, who is one of the founders of the Egyptian Society of Nephrology and Transplantation. He is the consultant and professor of nephrology and medicine in General Organization of Teaching Hospitals and Institutes, and the past head of nephrology department and internal medicine department in Ahmed Maher Hospital in teaching hospital and organization and institutes. Welcome, Professor Walid. And our great speaker today is Professor Hesham Elsayed. Professor Hesham Elsayed, the President-elect of Egyptian Society of Nephrology and Transplantation. CME chapter, this is the CME chapter. He is the hemodialysis chapter chair, Egyptian Society of Nephrology, and the African Association of Nephrology Afran Hemodialysis Committee chapter chair. He is the president-elect of Egyptian Society of Nephrology and Transplantation. Of course, Professor Hesham is a emeritus professor of medicine and nephrology in Ain Shams University, and he is one of the great scientists in that part of hemodialysis in Egypt. We will discuss today the topic of hemodialysis stress, induced stresses, and in the form of the lecture and the following discussion of this important topic. Please, Professor Walid, take the floor, read this meeting, and further introduce Professor Hesham, and we will listen to the lecture and come back again after the lecture for the discussion.
Thank you, Professor Elsayed, for this nice introduction. I'd like first to introduce Professor Hesham Elsayed. I'm a little bit older than Dr. Hesham, but I've always seen him a genius.
Thank you very much. My teacher.
He's a fact. He's always a genius. He's always the first shotter in every scientific argument. He has a very, very deep background reading. At this very moment, whenever there is something problematic about dialysis and its mechanism and dynamics, I always talk to Hesham to tell me or to teach me the right thing to do, whether to use the flow, the blood, etc., etc. He has a lot of depth in this field to the extent that he became a reference. Now, I really am not oriented about this topic, which means stress. Is it chemical stress, psychological stress? In his, as usual, very interesting and absorbing talk. Go ahead, Professor Hesham.
1 second, please. I am to thank our coordinator today, Dr. Islam Ghunema, lecturer of nephrology and medicine in Cairo University, who is the coordinator of this session and of all of his CME chapter activities. So please, Professor Hesham, start.
Thank you very much to my great friends, Professor Walid, Professor Yasser, for your, I'm very pleased to hear that, but actually I didn't deserve all you had said. I hope that we can have in this today talk something to be of value, and for sure, or our aspect today is to have some new information to our colleagues and fruitful discussion with all the crew. So today, as you know that Professor Yasser had addressed me the hemodialysis-induced systemic stress. It's a very big issue. It's not one issue. It's a huge issue. So all the following slides could be a separate talk. However, I will have a panoramic view on the talk, and I will not touch too much of the hemodynamic instability because we discussed it before. So along the agenda, we have to understand the stress factors and multi-organ damage. What about cellular response in dialysis, solute flux, sodium and water accumulation, acid-base changes and secrets in bicarbonate dialysis, endotoxin transfer. I will just highlight the arteriovenous fistula stress and it. So all of these topics will come in a panoramic view. I hope that to cover. So what about stress, as Professor Walid asked? What's about stress? We have a hemodynamic stress and a non-hemodynamic stress. We have an end organ damage, and we have a long-term outcome. So all the patients' requirement for dialysis is missing. Actually, hemodynamic stress is one of the leading of the mortality. However, non-hemodynamic stress is always behind the scene. And you will see on the following slides how it's a battle during hemodialysis between the patients and the extracorporeal blood circuit. So let us take an advantage of that. What's about the stress? We can have a biological stress, including uremic toxins, electrolyte, swinging acid, base, and fluids. We have a psychological stress, including death, depression, and anxiety, sexual dysfunction. We have a social stress, not only on the patients, but on the non-formal caregivers as well. We have ultimately multi-organ damage, and including that the cardiovascular death for the patients. So for my latest publication in the last editor in Stockholm, I presented one of the multinational studies, including in these studies a lot of countries, including from Egypt, and I'm from Egypt, UK, USA, UK, Germany, Taiwan, and the others, Mexico. So we presented that as a caregiver, non-formal, and the family burden on the patients, social distress, and escaping from the work, financial burden, and a lot of that. It's extremely huge burden, stress. And to my opinion, if I am talking about the stress on dialysis, I will talk about the non-formal caregivers and the patient-related stress on the society and social engagement, work, and the financial deprivation. So this is one of my latest oral presentation in Stockholm, discussing in different countries and the same results equally in developing and in developed countries as well. So it's a huge problem. Let us have a view on hemodialysis, what's unphysiological hemodialysis. 4 hours of dialysis, you can change the world in 4 hours, including you have 80 liters of blood are exposed to the extracorporeal circuit. Such processed blood of 80 liters of blood are in battle with 120 liters of dialysate, 3 kilometers of dialysis membrane length, facing more than 20,000 millimole of electrolytes. Huge electrolyte exchangeable between the patients and the dialysate. We have swinging in the blood pH, and the patient may lose 4% or more in a single hemodialysis session. So all these criteria makes us to think about what dialysis can have, hurting the patient as much as can benefit the patient. All this battle, including in the hemodialysis, weaponry body response. So body response is important in this topic because body response to external extracorporeal facing such huge deviations of electrolytes, fluids, and dialysis membrane who has a weaponry body response. This weaponry response including billions of cells, neutrophils, macrophage, monocytes, platelet, and others coagulation factors. Complement is well known to be involved in dialysis, hemodynamic, battle, coagulation, volume, electrolyte, acid-base changes, and importantly, osmolality shift during dialysis. So Such weaponry, body response, I will focus on that in this talk to understand what's happened during 4 hours of hemodialysis session. So dialysis-induced systemic stress, we can have here adaptive mechanism with consequences, functional, somatic, and others. We have to look for disease modifier. We can have increase in uremic symptom relief by removing much of uremic toxins and including that the inflammatory cytokines and complement factor D, and we have to minimize the dialysis-related complications. So if we can have the stress factors, we can have a disease modifier to have a better outcome in the patients. Looking for the patient-reported outcome, including the patient symptomatology, sleep disorders, restless leg syndrome, difficulty, cramping, constipation, sexual dysfunction, all these factors, unfortunately, are well covered by a hemodialysis and physiology. One of the most important factors that always, as a nephrologist, neglect is the post-dialysis fatigue. Post-dialysis fatigue is an important symptom to the patient. Subsequently, escaping from the midweek dialysis session as he feels tired, almost all after the end of the session till the next session, so no quality of life. Such post-dialysis fatigue still have multifactorial, but no definite management are active. We have ultrafiltration volume, hypotension, ischemia, elevated lactic acid levels, branched amino acid, and loss in dialysate. We'll talk about that in a couple of slides. Sedentary life and function disability. So this is one of the greatest stress to the patient to feel tired and fatigued all the day. The unphysiology of hemodialysis with fluctuation of extreme cycling of fluid status and osmolality, rapid change of electrolyte and acid base, and impaired detoxification and removal of uremic toxin efficiency with the therapy. By Bernard Cano, couple of years production of this nice graphic that circulatory stress and electrolyte, osmotic, biological, and thermal will end in systemic circulatory stress and end organ damage. And if you look here, what about our renal replacement therapy and dialysis modality? How we can adjust in a convenient way the time, the schedule, the quality assurance, how to protect the residual kidney function. All of these factors should be included in our approach and the management of hemodialysis program. One additional problem is the removal of protein-bound uremic toxins. As you know, that protein uremic toxins cannot be removed by hemodialysis due to its huge high protein content. More than 95%, for example, pliclitol sulfate and hydroxyl sulfate are 95% protein bound and could be. So this is one of the inefficient dialysis tragedies. Let us go deeper and dive into what the cellular and the complement activation with dialysis membrane can happen. We understand that hemodialysis membrane can have a lot of function here, the contact with complement and neutrophil activation, macrophage activation, platelet and leukocyte aggregation, and on other way, we have a coagulation cascade activation. This coagulation cascade does not end by the filter clotting. It has a long journey inside the body with activated coagulation factors, and they play a major role in thrombosis, in atherosclerosis with inflammation and others. So the marker of filter or extracorporeal clotting does not end by the 4 hours of dialysis, but extend without end to the next sessions of dialysis with active cellular component. So if you have, look in here, we have, for example, we have coagulation activation by Hegman factor, factor 12. We have complement activation and frustrated phagocytosis. Actually, this is my MD thesis, 1990. We tested for Hegman factor and complement factor 3B. Up till now, from 1990 till now, from my thesis and illustrating interleukin-1 production during dialysis and the complement C3A and C5A production 25 years with no improvement. Yes, we have improved dialysis membrane. We have improved a lot of the biocompatibility of water treatment and uremic extraction, but still it's annoying cellular reactions inside. Accordingly, the complement activations, the endothelial dysfunction, and oxidative stress with inflammation can induce cardiovascular disease. We know that more than 50% of patients die from cardiovascular disease. So we have to think about this puzzle. It's not one entity, but it's like a puzzle, all one piece, putting in the same dialysis session ending by cardiovascular mortality and all-cause mortality. It's called something in the secrets of dialysis, what's about the Vorman effect. Vorman effect meaning that protein adsorption on the dialysis membrane starting from the molecular weight like fibrinogen into the charged surface and its later displacement by high molecular weight and other plasma proteins. Such a Vorman effect with the blood flow inside the hemodialysis membrane and the protein denaturation can induce a huge activation of immune system with activation of coagulation system. So protein usually absorb inside the membrane during the first hour, and such a protein absorption will subsequently will induce more protein absorption and a cascade of inflammatory reactions and activation of cell. So denaturated protein triggers the activation of coagulation, immune inflammatory response at the membrane surface during the dialysis. We understand that inflammation in CKD, and we had added to the patient with CKD additional dialysis-related factors, including bioincompatible membranes, dialysate pyrogenic, vascular access infection, especially the castor, exit site infection, peritonitis, high glucose in peritoneal dialysis in PD sequence. So what about inflammation in the stage renal disease and dialysis? We have a lot. We have an exogenous factor such as dialysis membrane and castor. We have, on the other hand, cellular factors such as oxidative stress, cellular senescence, tissue factors such as hypoxia, fluid and sodium overload. We have microbial factors such as immune dysfunction and gut dysbiosis. And finally, we have additionally on that the retention of uremic toxins such as inductyl sulfate, advanced glycation in the products, and the calprotein particles. So all these 5 steps in dialysis, meaning to us that we are not doing dialysis procedure that can protect the patient. So non-hemodynamic stress, including complement, netosis, and we'll come back in the next slides, inflammation and oxidative dysfunction, and coagulation mediated. And if you look to this graph, one of the major problems till now is the complement, inflammation, and oxidative stress. Adding to that, what's called netosis or nitropholosis, which is an oxidative stress by myeloperoxidase release with circulating free DNA and histones. This item had been emergent a few years ago, and including not only on dialysis, but other inflammatory diseases. Such inflammation induces acute systemic stress, the persistent stress with the vascular memory. Here in this slide, it's a few years ago that hemodialysis induced marked adhesion of platelet to its surface and increased surface expression of CD11 and the production of much of cytokines. Hemodialysis as well, hemodialysis membrane could share the dilemma of inflamed aging, and this particularly is mainly induced by dysfunction of neutrophils, monocytes, natural killer, with signaling mediated by toll-like receptor 4. Activation of the complement system mediated by dialysis membrane system. So inflamed aging, the biologic age of the patient is affected. And this includes on dialysis regarding the innate response with inflamed aging and nuclear factor kappa beta with impaired autophagy, changes in proteases with mitochondrial dysfunction or microbiota dysbiosis and cell senescence. So all this happened during dialysis because it's a foreign surface, and all body cells will react accordingly to a foreign surface. This is called what is the same stress with two sides of the same coin, hemodynamic and non-hemodynamic factors with increased risk for all the abnormality. And this is one of the slides coming recently that patients against normal control, healthy control people has interleukins increase 6 and 8 inside their blood pre or post hemodialysis against the healthy control. We have also, for the immune reaction, we have a thymus involution. And these thymus involutions could be related to decrease of the cytokines like interleukin 7 and interleukin 22, which could be as a protective and survival and proliferation of the thymocytes. The dialysis procedures, biocompatible membrane, iron, inflammation can increase thymic epithelial cells involution. And potentially causes of such is still one of the mechanisms of inflammation is our dialysis procedure. So dialysis procedure extend to the thymus involvement to reduce thymus output of naive cells, to extend the hemostatic expansion of peripheral T cells. We have a controversy here. We have very active neutrophils and macrophage and platelet during dialysis, and very weak after the battle against the microbe defense. And so we have swinging between active immune response to, on the contrary, to low immune response to organism after the dialysis session. NETosis provides a link between activation of neutrophils on hemodialysis and comorbidity. A huge amount of weaponry in their granules in neutrophil, so destroys the pathogens. Activation through the NADPH lead to mass generation of reactive oxygen species. There is many types of NETosis. Traditionally, two types, what's called suicidal neutrophils and the live neutrophils. In all case scenario, whatever the neutrophil suicide for fighting against the organism or the membrane, the net result is a neutrophil extracellular trap. And this neutrophil extracellular trap formed by activated neutrophils during the process of NETosis, in which nuclear material is released into the extracellular space, including DNA molecules and histones. And it's documented in the research that NETosis happened during dialysis. So we have what's called early or vital NETosis without neutrophil death, or late, what's called suicidal NETosis after death of the neutrophils and release of the phagocytosis, chemotaxis, and granulations of the neutrophils. So this is one of the examples what's happening behind the scene inside the dialysis. We have high activity during hemodialysis. On the contrary, low response after hemodialysis by exhausted neutrophils by NETosis. So once this NETosis, that's a slow cell death, and non-lytic NETosis, rapid release from the lymph cells, and this could be an example of the cell death pathway termed NETosis in the dialysis population. The circulating free DNA in dialysis had been documented in several studies. After dialysis with 30 minutes and after 240 minutes with increase of circulating free DNA. It doesn't differ between short and long days. However, it's immediately happen inside the hemodialysis. So one of this category of NETosis and the DNA is known, and for sure dialysis has an elevated circulating free DNA in dialysis, and this elevated circulating DNA can induce more elevations and ending by endothelial cell dysfunction, cardiovascular damage, thrombosis, and what's called sterile inflammation. So NETosis and neutrophil traps will induce to free circulating DNA and histones inside the blood. And this example, what's happened here, we have a bacterial translocation or pyrogen or endotoxin from the dialysate fluids and bacterial-derived products like polysaccharides. On the other hand, we have loss of antioxidant losses during hemodialysis. So by the end, we have a net pH oxidase and inflammatory reaction inside with loss of important components of antioxidant during the dialysis. It is estimated that concentration can be increased by 50% in patients with other diseases. And this graph is also documenting that the patients with high circulating DNA has a higher level of mortality against patients who are alive with lower level of circulating DNA inside. Its a clinical implication, longer dialysis vintage, greater comorbidity and burden, increased level of inflammatory markers, including high sensitivity C-reactive proteins, tumor necrosis factor, and alpha. So this is one of the secrets, including also in renal transplantation, that circulating DNA, according to the histological biopsy results, that could be related to antibody-mediated rejection or acute T-cell-mediated rejection with higher circulating DNA inside the blood. So we have renal dysfunction, comorbidity, inflammatory state, metabolic disorder, and determinant of hemodialysis effect. What we can modify our therapy? We discussed about inflammation and neutrophil activation. One of the important tasks in dialysis is to improve by hemodiafiltration. From my side and my colleagues extensively studied this project for more than 3 years. And we did a lot of biomarkers. We tested complement factor D, which is mediating the activity of the complement. We found that we can remove complement factor D by hemodiafiltration. We can reach 52% of removal of factor D. Also, we tested the asymmetric dimethyl arginine tumor necrosis factor, and we found that its hemodiafiltration can play a role to modify such cytotoxic inflammatory and asymmetric dimethyl arginine. Who does not know dimethyl arginine? It's important in nitric oxide production. So dimethyl arginine block nitric oxide synthetase and decrease nitric oxide with subsequent decrease in the cellular nitric oxide. We also tested fibroblast growth factor, and we can improve by removing by hemodiafiltration. We are testing as well a lot of cytokines, including in tumor necrosis factor, interleukins, kappa and light chain and lambda light chains are inflammatory markers. Alpha microglobulin are the target biomarker now for dialysis adequacy. It's a huge molecule, around 32,000 Dalton. So pentrexine, we are preparing to publish that pentrexine. You know, pentrexine as endothelial injury. And interleukin-1, again, removal by hemodiafiltration. We can reach 80% more than better than urea. So we have to think about standardization of hemodiafiltration. How we can adjust our systemic stress? We can find clinical, biological, instrumental, imaging. We can use our tools to understand by imaging technique, by clinical techniques, or by laboratory techniques. Example, we can check for the cardiac, routinely brain, gut, liver, vasculature, and residual kidney function. We understand there is cardiac stunning. We understand there is ischemic injury of the brain with white matter infarction and called silent infarction in hemodialysis patients. We have to adjust our fluid overload status between swinging hypervolemia in interdialytic period and the hypovolemia during the dialysis session. We have to improve all unexpected events, improving the poor quality of life, the fatigue, and to prevent end organ damage. Coming back to the physiology of hemodialysis, the biochemical stress, including electrolyte, physiological, and the biological fluctuation carried intensity and intermittently during dialysis, alter the body composition, large osmotic biochemical composition changes, removal of useful substances such as glucose, amino acid, nutrients, vitamins, antioxidants, and aggravating other stress of circulation through the endothelial cells. Hypoxia is well known. I will not go through that in details, but you have to understand that hypoxia could be related to this rapid shift of the pH from acidosis to alkalemia by giving bicarbonate dialysis and respiratory center depression. Additional biomarkers is needed in the nutrition and inflammation. We have to seek the protein diet of the patient. We have to consider the pro-catabolic effect of the dialysis and the anti-anabolic factors like inflammation, anorexia, gastroparesis, deficiencies of vitamins, protein, and amino acid loss. I will come in a moment on that. We have to improve hemodialysis-related factors by limiting efficiency of renal replacement therapy with unphysiological profile. On the last few years, there was an interest about amino acid loss during dialysis, including branched chain amino acids, and a lot of studies describing that either by only plasma testing or by testing on the dialysate amino acid. Here in this study, it's a new study showing that plasma level of branched chain amino acid decreased significantly in post-dialysis and could be one of the factors of post-dialysis fatigue. Supplementation of amino acid or protein intake may ameliorate that. Additional studies that about 12 grams of amino acid were lost via the dialysate. It's a huge 12 grams of amino acid in a single session, and are classified where non-essential, essential amino acid, branched chain amino acid, all are removed during the dialysis. And if you look for this by calendar data, a couple of years ago, there is increased risk of death by albumin among 20,000 patients on dialysis if you have a patient's albumin as low as 3.5 and less, which is common. This figure is very common in our patient between 3.5 and 4. A little patient can reach 4 grams per deciliter albumin in the plasma. So if you look to this column, if you have around 3 to 3.5, which is the majority of our patient, you have a huge risk of cardiovascular and all-cause mortality. So we have to take care about nutrition and the albumin level in our patient as a routine check, monthly check, and encourage patients to improve the inflammation and the dietary control. Frailty is related to and osteopenia and frailty-associated hospitalization and death. Sarcopenia, one of the catastrophic in our dialysis with frequent fall from frailty and weakness of the muscle by sarcopenia, all are included. So this is the part of inflammation and subsequent hypoalbuminemia, amino acid loss, and inflammatory reactions, neutrophil, and the petals of the cellular component. Additional cellular component, I will not touch too much, which is the hypersensitivity, but in general, the prevalence of allergic reaction is thought to be underestimated. We have an allergic reaction, but not to the clinical setup. We understand there's two types, type A and type B, through IgE mediated or non-IgE mediated or complement mediated. Both of them are multiplicity of potential exposure and complexity of the environment to the patient on dialysis. Great diligence is needed to investigate hypersensitivity reactions to avoid recurrence in this high-risk population. I will talk about my colleagues and friends online who are using 20 years ago dialyzer with ethylene oxide. It was first-use syndrome cold and hypersensitivity reaction, and it was high immediately starting dialysis with chest pain and back pain. But if you remember that equally, you will know that we have a little hypersensitivity reaction, but put in your mind that blood tubings, blood lines, others like fistula needles are still ethylene oxide. So you didn't vanish ethylene oxide from extracorporeal, but you remove it from just the dialyzer. Swinging on the solid flux. On the battle of cardiac arrhythmia, hypoxemia, solid flux, and inflammation, all are sharing the end of electrolyte imbalance during hemodialysis. We have to personalize electrolyte in the dialysis prescription. Take care about that. We have a rapid correction of acidemia, low serum or dialysate calcium, and the high ultrafiltration rate may contribute to arrhythmogenic potential of low potassium dialysate. So we have an acute event with probable sudden cardiac death from dialysate prescription, and we have a long-term effect like CKD, Menard-Pont disease, cardiac remodeling, heart failure, and subsequently left ventricular hypertrophy. The trigger events still here: the electrolyte flux, myocardial ischemia, dialysis-induced hemodynamic stress. Let us take snapshots from each of the electrolyte. Patients' emergency department visit shows that whenever there is a gap between the dialysate and the blood, the hospitalization increase. You can look here for this. If you have a higher gap, you have a higher rate of hospitalization. So patient presented typically by a serum potassium above 5.5 is described that hyperkalemia prior to dialysis. And those patients had an association between pre-dialysis serum potassium and the mortality risk in patients. It's a U-shaped parameters. If you have a serum potassium below 4.5 or above 5.5, the risk increase. So this narrow gap between the normokalemic status before dialysis, either pre-dialysis hypo or hyperkalemia, carries the same risk. So be cautious that to educate the patient or prescribe resins if required in between dialysis to optimize the pre-dialysis potassium between 4.5 and 5.5. We never use potassium prescription in dialysate by 1 millimole because we always use 2 millimole according to the guideline and according to all the publications that 1 millimole dialysate potassium should be forbidden. Sudden change in serum potassium will provoke excitation cycle inside the heart and can induce arrhythmogenic effect during the session. On the 4 hours after hemodialysis, the excitability of the myocardium is still present, and the patient may experience hyperkalemia later on as a rebound effect. So one of the little thing to think about dialysate bicarbonate. Is it too much of a good thing? Yes, it's a too much of a good thing. Dialysate bicarbonate has been used for years, better than the acetate, more for the hemodynamic stability, and actually it's a good thing of bicarbonate, but it is not fully innocent. It has a lot of complication, as we can see here in the couples of slides. So simply we can say that dialysate bicarbonate, it is too much of a good thing that will lead to a lot of complication. Swinging between acidemia and alkalemia during the session. Here in these graphs, you find that the contrary. You have an intradialytic event and interdialytic event by hydrogen. So hydrogen play a major role here, either inside and after the dialysis session. While the interdialytic event removing the hydrogen and giving bicarbonate to the patient, still you need more bicarbonate to precisely individualized to each patient. No centers in the world are doing pre-dialysis bicarbonate to adjust the hemodialysis machine bicarbonate accordingly. But in general practice, we have to be in the guidelines, not to give too much and try to do a bicarbonate level for the patient at least once monthly to control. Let us see that graph. There is swinging between the serum bicarbonate inside the dialysis station. You can find that between 28 and 32, and the dropping back on the dialysis interdialytic period. So you have a huge variation in the serum bicarbonate and correlated with the acid base. One of the new approach is to individualize and to do a bicarbonate like sodium modeling techniques is to do bicarbonate modeling technique, where this is a traditional bicarbonate or conventional hemodialysis that increase the time on dialysis against the blood bicarbonate sharply during the first 2 to 3 hours, and then stabilizing. While staircase protocol is to increase the bicarbonate gradually, like sodium modeling, during the whole dialysis session. In this nice study comparing the constant dialysate bicarbonate against a bicarbonate of 35, then 30, or the reverse bicarbonate 30 to 35, you can find that the treatment A, who begin with a fixed formula of bicarbonate, has a higher ratio of bicarbonate. This reflecting on the swinging of the pH and carries the risk of bicarbonate CO2 production. CO2 production during dialysis is completely a missing point. Nothing recall CO2. CO2 is the final diluted dialysate is 2 to 3 folds the quantity found in the uremic blood entering the extracorporeal cell. This larger dialysate blood difference accounts for very high CO2 dialysis, meaning that shifting of CO2 from the dialysate to blood side, and in turn for a sizable transfer of CO2 from dialysate into the blood coming back to the patient. This is the CO2 load on hemodialysis. If the patient has a normal respiratory system, it will be washed through the lung. However, if the patient already has CO2 retention, it will be problematic and may explain to a great extent the CO2 narcosis during and after the dialysis session in such population. The interdialytic period with low pH and serum bicarbonate, however, during dialysis, along through the path of the dialysate, bicarbonate and alkali are transferred to the patient, while bicarbonate are forming into water and CO2. On the same side of the path, the bicarbonate generates CO2. Rapid increase in blood pH and serum bicarbonate by alkali can induce hypercapnia from CO2 retention. On the same side, alkalosis will induce respiratory changes and hypoventilation. So hypercapnia can be observed in patients due to synergistic effect from alkalosis shift, respiratory center depression, or from CO2 production and not washed efficiently by the lung. Also, the pH changes can induce immune system deficiency, can induce risk of infection, can have a progression of vascular calcification. So the summary of CO2 transfer in hemodialysis, I understand that very critical point and usually is lacking in our clinical practice. After mixing the acid concentrate, any bicarbonate solution contain the canister contain some of acids, it's around 3 to 5 millimole. After mixing of the acid concentrate with bicarbonate containing solution, the CO2 in the dialysate ranges between 80 to 100 millimeter mercury. Arterial CO2 is commonly below 40 because the patient is acidotic and hyperventilated. However, this leads to high CO2 dialysis, transfer of CO2 from the dialysate to the blood, increasing to a sizable increase in CO2 in blood and returning to the patient. Adding CO2 normally is quickly removed by respiratory and systemic BCO2 remains essentially unaffected, provided your patient is conscious, is not sleepy, has a hypoventilation, he has a CNS capable of reactions to CO2 to increase the respiration. So abrupt bicarbonate influx, although it seems to be innocent on the behind the scene, it is not innocent 100%. You will have acute rise of pH, can cause hypoventilation and respiratory depression. Alkalosis depress tissue oxygen delivery by inducing vasoconstriction and shifting of the oxygen dissociation curve to the left, impairing hemoglobin ability to release oxygen. Alkalosis can induce tissue hypoxemia and adversely affect vital organs. And finally, abrupt reduction in circulating hydrogen acutely reduce the circulating ionized pool of calcium, so leading to functional hypocalcemia with subsequent neuromuscular and end-organ damage. And this is classical diagram of CO2 increase inside the dialysate, and such increase of CO2 should be by CO2 exhalation, provided we have no problem. But if you have obesity, for example, or COPD, pneumonia, or pulmonary congestion, you have to think about CO2 transfer and check blood entering and leaving the dialyzer for CO2 pressure. So the dark side of bicarbonate CO2 are the CO2 transfer from the bicarbonate. It is used in clinic, so it's one of the black comedy. Do you understand that this black comedy, after revisiting the CO2, they can have a CO2 arteriovenous fistula recirculation test. The value is to measure the pre-dialysis patient CO2, then to remeasure the CO2 again in the pre-filter sample. So if the pre-filter sample has higher CO2 than the starting dialysis session, you can say that it's increase in CO2, providing that the lung and ventilation are normal. It's a very simple technique. Patient first, before starting dialysis, we will check for CO2 level. After half an hour, we can recheck back again the blood entering the filter for CO2. The venous end will have high or huge amount of CO2 transferred from the dialysate. So the CO2 coming out of the dialyzer should go to the lung. But if recirculation happen here, the pre-filter or the arterial line will have a higher CO2 than the resting or the pre-dialysis. It's a very simple technique just to check for the possibility or probability of vascular access recirculation, and you can confirm by either the Doppler study or urea-based recirculation test, but testing CO2 pre and inside the dialysis on the arterial line could give a hint of recirculation, and they have a nice name called recirculation CO2 testing. Coming to one of the missing electrolyte in the field, the magnesium. We understand that we have a fixed formula of magnesium of 0.5 millimole per liter, and such magnesium will have loss during dialysis if the patient magnesium is around 2 millimole. So regular monitoring of plasma magnesium concentration is certainly necessary in patients. An optimal magnesium still have a U-shaped or Y-shaped category, that if you have a patient with a serum magnesium pre-dialysis around 2, the risk of adjustment hazard ratio is high, and you have a magnesium above 2.7 or 2.8, you have an increased risk. So we have a narrow gap like exactly in potassium. Adjusting the patient magnesium in around 2.5 to 2.8 seems to be safe, because simply if you are using a dialysate magnesium of 0.5 millimole and you have a normal serum magnesium of 2, there is a moderate elimination of magnesium during dialysis. If you increase the magnesium to 0.75 mole, you will have a moderate uptake, and if you increase more, you will increase the uptake. On the contrary, usually we have a fixed formula of 0.5 according to the guideline. To my knowledge, there is no concentrate above 0.45 millimole in magnesium. Magnesium has a cardiac excitation, potential effect of magnesium depletion process during the different phases of action potential, including myocardial stability. Sodium, the great player in dialysis. How to adjust the sodium pre-dialysis and how to evaluate the interstitial, skin muscle, arterial sodium, and skin and other tissue with the emerging MRI scanning of sodium tissue sodium. Individualization of dialysis sodium prescription is hard. To measure that is very hard to do pre-dialysis sodium, and to keep the dialysate sodium around above 2 millimole above the patient is difficult to be applied. So the precise management of sodium in hemodialysis, you need a sodium monitoring, but still you cannot do it by routine lab work. So this is the emergent part of the hemodialysis machines on the recent few years is to give a zero balance between patient and the dialysate sodium. Increasing dialysate inflammation and sodium and endothelial dysfunction by increased sodium storage. So sodium is not only related to interdialytic weight gain or blood pressure, hypertension, it's related to other increased tissue sodium storage with catabolism, inflammation, heart failure, lung edema, liver, gut translocation even can induce proteolysis and endothelial dysfunction. The new technology improved that by the 8 potential benefits of a new technical solution. Meaning of technical solution is to have a zero sodium transfer to the patient. We can improve sodium monitoring, handling, metabolic, cardiovascular outcome, and the hemodynamic status. Let us have a look about what this technology can be. It's completely automated, and this automated individualization of dialysate sodium concentration reduces the intradialytic plasma sodium changes, and it depends on a zero diffusive sodium balance in hemodialysis provided by algorithm-based electrolyte balancing, and it's present actually in many of hemodialysis machines by conductivity meter that can have a basics of measuring the electrolyte balancing controller. It's called electrolyte balancing control system by measuring the inlet and outlet of the dialysate conductivity. In and out are measured by conductivity cells. So we don't have the need to give a blood sample for the patient. The controller adjusts the dialysate inlet sodium in order to achieve zero diffusive sodium balance according to the patient. And such a change of sodium concentration, again, is a standard fixed sodium. You have a varieties, but if you have a zero diffusive sodium by the automated form of sodium panels inside the hemodialysis machines, is better. I will not go through to the hemodynamic for the sake of the time. We discuss it for a very long talk, and its stunning effect. Organ damage in the brain. How many of us are investigating the patients on dialysis according to cerebrovascular blood flow? Cerebrovascular disorder in hemodialysis usually is missing and usually is silent. There is increased tenfold higher incidence with case fatality rates about 90% in cerebrovascular stress and stroke. It's due to high hemodynamic fluctuation, blood pressure changes, effective dialysate and anticoagulation, dialysis-induced amyloidosis, vascular calcification. Years on dialysis also may trigger both ischemic and hemorrhagic stroke. So we have a long list of CNS complications on dialysis. Most of them are modifiable factors. So we can look about all of these factors and the risk of cerebrovascular accident and modify our treatment accordingly. I saw a lot of patients with cognitive dysfunction immediately following dialysis. I don't know, is it just a mechanism or is due to one of the dialysis disequilibrium syndrome? By the way, it can happen on chronic hemodialysis patient, not on initiating hemodialysis. So cognitive impairment in renal transplantation is found in our clinical life, could be related to uremia, inflammation, or more. I will go more for the endotoxin. I published that probably 7 years ago or 8 years ago on the annual Dallas conference in University of Missouri, Division of Nephrology, 2016, and we found that endotoxemia of patients on dialysis carry high risk of cardiovascular disease. And just published 1 year ago that using a central dialysate delivery system can have a good impact on reducing the interleukin-6 and CRP level in prevalent hemodialysis patient, meaning that water path is important to seek the endotoxin level and to improve the pyrogenicity effect on that. Last, my points is the activation of coagulation. It is not ending on the clotting of the filter or the extracorporeal circuit. However, it has a huge dilemma. 1 year ago, I published that activation of coagulation system, including thrombin antithrombin complex, and this is in therapeutic apheresis, a couple of years ago, or 1 year ago, exactly February 2023, and I found that thrombin antithrombin complex are increased nearly the double on the baseline, meaning that on different dialyzers, so it is not related to single dialyzer, increasing of the TAT or thrombin antithrombin as a start, and at the end, you can find that huge increase in the thrombin antithrombin complex, meaning that activation of complement is a player, again, on the hemodialysis-induced stress. Production of prothrombin, thrombin could induce atherosclerosis, organ coagulation, release of procoagulations inside the circulation. So as I said, that it doesn't end by filter clotting or extracorporeal clotting. And here is some of the recent research in the dialysis membrane, vitamin E coated or heparin coated dialysis membrane on the theory of, again, activation of neutrophil, production of neutrophils, extracts neutrophil platelet thrombus formation. However, all these studies does not have a long-term effect on the patient's outcome, including heparin-coated dialysis membrane. On the same of coagulation, on the contrary, as you know that hemodialysis is always a contrary. You have that obese patient has more advantage for living against the general population. You can have serum cholesterol in patient on dialysis. If low, carry worse prognosis on dialysis. And the same contrary again in dialysis. If you have a thrombocytopenia, you have a bleeding risk. However, in hemodialysis, heparin-induced thrombocytopenia, meaning risk of thrombosis. So again, it's one of the contrary and contradictions of dialysis-induced dilemma. We have two types of HIT, mild or immune-mediated, and in brief, you can diagnose by either an absolute number of thrombocytes below 150 or a fall more than 30% from baseline platelet. Unlike other thrombocytopenic disorders, the low platelet count in HIT don't increase bleeding risk, but rather serve as a marker of thrombosis. And here is the 4T's clinical scoring. If you have 4 or 5 points, I will not go to the details. You have a higher probability of thrombosis. Again, the same players come in coagulation, monocytes with heparin, immune complex attachment, neutrophils. Again, we have netosis by activation of the heparin-induced thrombocytopenic antibodies. So the same game are repeated by different players, pyrogens, microbes, impurities, and even production of antibodies in heparin-induced thrombocytopenias. Fresh frozen plasma can help, but it's very transitory effect. This transient effect of plasma exchange could be just for emergency treatment. However, it's a very time-limited and short action. And this is a grading from the latest ASFA 2023, according to therapeutic plasma exchange with heparin-induced thrombocytosis and thrombosis. It's category 3 with subjected problem in the anticoagulation because low molecular weight heparin cannot be used with HIT. So argatropan is implanted in this category of patients and need to be adjusted in the dose of around 2 microgram per kilogram per minute as an infusion. So, Mr. Chairman and dear colleagues and my friends, all over the trip of battles of hemodialysis-induced stress, we have to look about all behind the scenes, improving our care and do a personalization of care and take care about the ugly fistula. It's important factors on the next talks about high flow heart failure. We have to think about, we touched the intradialytic period, we didn't touch the interdialytic stress as well. It's a huge between dialysis session is additional stress for the patient. Thank you very much. I hope that I didn't take too much of your time. Thank you.
Thank you, Professor Hesham, for your very excellent and comprehensive talk about all hemodialysis stresses. I have some questions, but Professor Walid, please. Professor Walid Masoud, unmute yourself, please.
Unmute. Okay. Okay.
Okay.
Can you hear me now?
Yes, yes, clear.
Thank you, Professor Hesham, for this talk. Really, I think just as you said at the beginning, every single topic mentioned about the stresses in hemodialysis needs a lecture of its own. It's very, very difficult to follow up all these problematic puzzles you gave us. However, I will go very simply from an inflammatory response of the release of these cytokines, but you did not give us a solution for each of these complications that you said, and I'm sure you have these solutions.
Actually, you know that, Professor Walid, we have a limited technical dialysis, but we have some solutions that can support. If you identify the major players in such a stress, we can at least manage our patient more safely. For example, we understand inflammation comes from impurities, dialysis membranes, extracorporeal circuit. So we have to be on the side of ultra-pure dialysate. It's improving the patient's well-being. We understand as well some of the extracorporeal changes of electrolytes. So we have to personalize the concentrate and the electrolyte delivery to the patient according to the actual patient measurements. We have to also personalize ultrafiltration. We have to give more time for the patient. So we have on our clinical skills, we can decrease a lot of the such stress or burdens. You agree with me that we are treating our patient as a single patient in individualization,
Yes,
in everything. in dialyzer
But
choice, in extracorporeal time, in electrolyte, in dialysis concentrate, in bicarbonate, all are the same. So I think that our approach for better outcome is to inhibit or decrease inflammation and to do more personalization for our patients.
let's take an example first, like these electrolyte shifts and electrolyte disturbances. Let's say the potassium and the carbon dioxide. Let's take an example as the potassium, which you said in a very interesting way that the narrower the potassium is nearer to the normal, the better the outcome is. If there is hypokalemia, it's serious. If there is hyperkalemia, it's serious.
Yes, exactly.
But this, if I'm going to individualize these treatments, this means that I have to subject my patient to a lot of investigations pre-dialysis. Is that practical in your own point of view?
It's not practical, but I have to check the patient routinely and regularly, not pre-dialysis every session, but at least to check his blood gases, bicarbonate level, pre-dialysis potassium, and adjust. For example, if your patient is persistently pre-dialysis potassium above 6, I have to look about the nutrition. I have to look about adding some of the resins. I have to make something. But pre-dialysis potassium, in most cases of scenario, above 6 in our clinical life, most of patients are presented by above 6 or 6.5. And we didn't touch that point with patient. We are insisting the patient to eat low potassium diet. And on the contrary, we are insisting patient to have a vegetable diet for additional benefits from dysbiosis. So I think one of the implementation protocols in France, for example, they are giving resin for 35% of patients on routine dialysis. So we can have some of the measurements to do in such a way. On the other hand, pre-dialysis potassium below 4.5 carry a risk. And if the patient is presented by low potassium, I have to check the nutrition status of the patient. Serum phosphates as well. Low hypophosphatemia is a nutritional status. Hypoalbuminemia is a nutritional status. And all of these carry higher risk of mortality, especially all-cause mortality and cardiovascular mortality. So we have some tools to do personalization, not on routinely pre-dialysis, each dialysis, but at least once per month. We can check that protocol for management for individual patients.
Now, the last thing I'd like to comment about is the oxidative stress with the release of asymmetric dimethylarginine or ADMA.
Yes.
And obviously in your beautiful talk, actually, but you did not mention how to get rid of the production of ADMA by the body, or here asymmetric dimethylarginine.
I tested 5 years ago the asymmetric dimethylarginine. I published this publication as well. Asymmetric dimethylarginine is a small molecule. However, its binding to protein is still of controversy. So you remove the free form of asymmetric dimethylarginine. You have asymmetric and unsymmetric dimethylarginine, and both are coming from the arginine metabolism. Both of them are produced as uremic toxins, and it's well documented as a nitric oxide synthase suppressor. Dialysis, yes, can remove the free form of ADMA, but not the protein bound form. You cannot manage how much of production. You cannot decrease its production.
Yeah.
But you can improve their removal during dialysis.
Well, obviously, I still insist that every single topic that you said about the stress should have a talk of its own, really. Lena, it's very interesting.
You was wondering about the stress, which is stress. So yes, exactly. We have tons and dozens of stress.
Yes.
During dialysis, and the equivalent number interdialytic period. So stress, yes, needs, but it's a panoramic. Just to my target is to give some insight about what is behind the scene, like CO2 generations and NITOSIS.
Yes, this
and
is other topics. CO2, to me, it was very, very strange. I mean, giving sodium bicarb or bicarbonate dialysis, releasing CO2 and water, and this CO2 will carry an impact, a negative impact on the body itself.
Yes.
Yes, I mean, it's a very, it's just like you said, it's a black comedy.
Yeah, black comedy, yes.
It's depressing. It's very depressing, really, yani, what we're doing. Anyway, I have to thank you. I could not follow in depth all what you said because it was too many information given, and most of these information were investigated by yourself and published even by yourself, which makes us proud that we have Hesham Elsayed as one of us.
Thank you very much.
Thank you very much. I have no other additions except if any of the other audience would like to add a question or so.
Thank you, Professor Walid, and thank you, Professor Hesham. Really, we are proud of these publications by Professor Hesham Elsayed. What made him, as I said, the great hemodialysis scientist of Egypt. Let me take your talk about individualization of electrolytes to avoid stresses, Professor Walid, and ask Professor Hesham about this. How can you in practice individualize these electrolytes regarding each patient? Even sodium, which we used in practice to individualize for patients, you said that new machines are working to not to individualize sodium, not to for each patient, or to work sodium according to the each patient parameter. So
No,
how can you individualize?
Yes, okay.
This is some sort of individualization, as I can understand, which is automatic.
It's individualization, but automatically, yes, diffusive sodium, zero diffusive sodium, so, depending on the in and out of the dialysate, and it's implemented in many of the modern hemodialysis.
By using sensors.
Yes.
So how can we talk about other electrolytes, including potassium, calcium, for example?
You cannot at the moment, but you have a gap and window. You can work for your patients in the monthly report as a director. You can check serum magnesium below 2.5 carrier risk, potassium above 5.5 or below 4.5 carrier risk. So one snapshot of the patient per month can highlight that the patients during the whole months of dialysis, we have to precipitate such knowledge. Once per month, blood bicarbonate level to be not less than 22 pre-dialysis, not more than 28 post-dialysis. So you can have one snapshot for each patient, one a month.
And so individualization is once per month, not per each session.
Yes, sure. You cannot do it every session.
I found this difficult really for each session. And regarding potassium, in spite of your advice to individualize, you said not lower than 1 millimole concentration.
2 millimole.
2 or 1?
No, you cannot use 1 millimole. It's in all publications.
Yes,
it's between 2 to 3. So 1 millimole is forbidden. The potassium 2 to 3 millimole per liter in the dialysate. What was in the factor 7? This is not scientific. Factor 7 to put the patient on the factor of 7 and to put the dialysate potassium. So on all patients, the dialysate potassium between 2 and 3. If you have a higher potassium up to 8 millimole, still you are using between 2 and 3. But if you have low potassium below such a level, you will need a potassium infusion or higher, like 3 millimole potassium. It's the same concept in glucose. 100 millimole glucose per liter is safe. So never to use below 2 millimole potassium and uncommonly to use above 3 millimole. So usually between 2 and 3. What's in Egypt is 2 millimole per liter.
2 millimole, this is what I know. So I want to
precise.
It's a fixed ratio, 2 millimole, and a magnesium of 0.5 millimole. So we have a low magnesium in dialysate, and if you check your patient, you found that if they have a serum magnesium below 2.5, for sure there is a transfer of magnesium during dialysis from the patient to the blood, to the dialysate. So ensure that each patient is 2.5 millimole or around of magnesium, not the normal from 1.8 to 2.2. No, it is not satisfactory in dialysis patient.
Okay. Let me take a
Can I
question
ask
from
a
the
question,
chat.
يا دكتور ياسر?
اتفضل يا دكتور
Can
وليد.
a question to Dr. Hesham. Now, if I have a potassium, the rule for equilibration between the intercorporeal potassium and the dialysate potassium. Now, if I have a potassium of 7, I start dialysis with 7, and I'm being dialyzed on a potassium of 2. This means that at the end, I will reach a potassium of 4.5, that is 9 divided by 2, or is this wrong?
No, it's not like that, because in all case scenario, each dialysis session removed from 70, 80, or 100 up to 100 if you prolong dialysis millimole of potassium from the body. The problem of potassium, it is not diffusible from red blood cells entering the dialyzer. And other cells, depending on the active transport, cellular transport, so there is no diffusion of potassium during the hemodialysis from the cells or the red blood cells or the cells inside the body. According to the clinical studies, that if you are starting potassium, for example, for 7, yes, you are correct. It could be around 4.5. But on the night, it may be by rebound to 5.5. The problem is during intradialytic potassium drop alone. It is with the rebound effect of
So even
hyperkalemia.
potassium has a rebound, which you mean
Yeah,
that potassium,
huge
yeah.
rebound. And this is in my clinical study I will publish during this year, inshallah, the rebound effect of hyperkalemia on patient on different dialysis modality between low flux, high flux, and the others. And we found that, yes, it's evident that potassium rebound happened.
I think
Thank
this
you,
was
thank you.
discussed together in the last annual dialysis conference, huh? The one we discussed together, huh?
Yeah, yes.
Yes, was lecture out. A question from the chat. From Professor Ahmed Yassin, and really, it's one of my questions. What is the optimum modality to avoid stress? What modality do you advise us to use to avoid stress as much as we can? Let me divide what hemodality of hemodialysis, or what hemodialysis prescription, and then what modality of dialysis in general.
For sure, hemodiafiltration carries a lot of things in inflammatory reactions, in the sterile dialysate, in removal of many of large molecules. We can reach, from my results, 40 to 50% of lambda light chain, which is 45. Accordingly, in all the clinical studies, the long-term effect is heterogeneous because of comorbidity. But if from my side, if I can apply hemodiafiltration to all patients, I will do hemodiafiltration for all patients. On the other hand, there is emerging technique of expanded hemodialysis or medium cut-off dialysis. Although long-term studies had not been, it's just 2018, so we are talking about 5 to 6 years. But it seems that medium cut-off or expanded dialysis as equivalent result with more difficult technically the post-dilution hemodiafiltration. So in all this stress, we can manage step by step from the cellular battle to the end of removal as much as you can. You can decrease or lower the stress factors in dialysis patients.
Can I ask another question? Just tell me what's your opinion about the modes that I give you, one session online HDF, and the other 2 sessions are conventional. Is that, in your opinion, is correct, ولا دي تأليفة مصرية؟
طبعا تأليفة مصرية.
بس خلاص أنا عايز أوصل المعلومات دي.
Just to our colleagues, hemodiafiltration dose is the total weekly dose of more than 70 liters per week. Each single session above 23 liters per session and above 25, but the total dose of hemodiafiltration is calculated by weekly convection volume that should be around 70 liters per week. So if you are giving the patient 23 liters per session, just to rotate the hemodiafiltration machine to apply to different patients. In the same way, if you don't have such dialysis hemodiafiltration machines, you can do it once per week. Better than nothing, but has no any scientific background.
I just wanted you to deliver the message. That's all. Yeah, I agree with you. Okay.
Okay.
Thank you, Dr. Hesham.
Thank you,
Dr.
Dr. Hesham. A question from Dr. Ibrahim Omar. How can we accurately evaluate the risk-benefit ratio of intensive hemodialysis from your long experience? I think this needs a long session.
Yes, intensifying dialysis has cons and pros.
Yes.
If not implemented inside the track, you will have more risk of prolonged dialysis. Even nocturnal dialysis techniques have been investigated for quality of life and mortality and cardiovascular death. The only augmented hemodialysis protocol what is agreed and applied right now is during pregnancy. Outside that, you can manage the patient by just adding sometimes or increasing the dialyzer filter or go to hemodiafiltration. Nothing about intensifying dialysis because there is a risk for the patients with vascular access and losing of important. Don't look about removing toxin. You are losing additional important issues like amino acids and toxin. As I always say that dialysis is blind. They cannot differentiate between what's good and what's is devil to be removed. So intensified dialysis meaning intensified loss of amino acid, vitamins, and minerals.
Thank you. A question from Dr. Inas Fauzi. You said that if there is hypokalemia or the patient is entering the session of low potassium, about 3.5, you can use adding IV potassium. But she is asking about, Dr. Inas is asking about adding potassium to the dialysate fluid. Do you recommend this or something?
It's manually prepared. We did before such a situation. We can calculate how much we can add to the concentrate to increase the dialysate potassium from 2 millimole to 3 millimole per liter. It's a calculation.
Calculation. But I think it is difficult to be given intravenous.
You can give it intravenous in the range of 10 to 20 millimole per hour. Yeah, that's the IV infusion of potassium obey the rule in ICU and on dialysis on the same way. But you never to give it in the line, pre-filter, because it will be removed from the line.
Okay, post-filter. Question from Dr. Masoud Khairi. Are these stress factors in correlation to resistant hypertension during dialysis?
Masoud is one of my students in the master degree. And I think, Masoud, you are relieved from the stress right now. So don't worry about nephrology. Nephrologist is
he is one of the regular. He is one of the regular attendants of this platform.
He's my student.
I think even more than me.
Yes, he's one of our friend. And Masoud was graduated by master degree in Shams of nephrology, probably 7 years or 6 years ago. What's your question, Masoud, about stress?
Which is stress? There is relation to the resistant hypertension?
No, to my knowledge, this is not factor. Despite that, maybe inflammatory stress may induce vasodilatation and escape phenomena. It carries what's called albumin translocation, which is vasodilatation and escape of the albumin molecules to the outside of the body by such or venodilatation, but it's not related to hypertension.
Okay, a case, I think we can, Professor Walid share us.
Yes,
patient has, from Dr. Asma, patient has acute kidney injury, serum creatinine 10
وليد يجاوب بقى شويه عنه.
ده الامتحان الشفوي
انا ما عنديش حاجه فيك يا هشام.
كله ضرب.
ده سؤال سهل ان شاء الله.
طيب.
Simple acute injury, creatinine of 10. urea 155, severe hyponatremia, sodium 100, severe hypocalcemia, ionized calcium 0.69, arterial blood gases and potassium accepted. Patient is disturbed conscious level. Your decision here is to correct hyponatremia and hypocalcemia first, or to dialyze first.
In my opinion, I will answer. Correction of hyponatremia is done easily by dialysis, because we have here a dialysate sodium of 135, مش كده يا هشام؟
Yes, the lower dialysate sodium can be reached is 130, and in some machines 128. You cannot go through that, but it depends on
it
the
will correct
sodium.
the hyponatremia. It will correct the hyponatremia.
Correct sodium. This will correct sodium, I think, rapidly, very rapidly.
Yes, exactly.
But here she said it's an acute kidney injury. This means that the hyponatremia developed recently and not chronic hyponatremia. So there is no risk for developing central pontine myelinosis. This is what she means.
I think there is still a risk, because it's only 2 days that differentiate between acute and chronic. And if you allowed me, is it euvolemic hyponatremia or hypervolemic hyponatremia? It's important.
This is the trick. This is the trick.
Can I add something here? Can I add something?
Yes.
Many times did we dialyze patients with serious hyponatremia, conventional, حتى واحنا صغيرين, without taking any precautions. And really, although I saw cases of central pontine myelinosis outside the dialysis, but I never encountered central pontine myelinosis on the dialysis patient. My explanation, I don't know whether this is right or wrong, it's that because the development of urea is high, and this has a high osmotic pressure, it will prevent the formation of osmolytes in the brain, and consequently the occurrence of central pontine myelinosis. That is why.
Correct. Absolutely correct. Absolutely correct. Because it's written in the literature that high urea is protecting against central pontine myelinolysis. On the contrary, can develop dialysis disequilibrium syndrome.
But if you allow me, I think no one would like to face such a complication of central pontine myelinosis.
Sure.
Even that it is very rare in dialysis patients, so you should be careful.
I never really encountered it in dialysis patients. I saw other clinical cases, but not in dialysis.
But if the patient has an acute kidney injury, you have two possible management protocol. If your patient has a euvolemic hyponatremia, whatever the cause, you can use either a CRRT, which is advisable here to start CRRT, not routine hemodialysis or conventional hemodialysis, because you can manage the dialysate as low as a border above the patient sodium, and you can monitor. So in patient with such scenario, true hyponatremia, euvolemic hyponatremia, I want to go directly to start CRRT and manipulate the pegs of CRRT or by glucose 5% infusion. If you don't have...
Can instead of CRRT being more practical, which is not always available even in tertiary hospitals, can we shift from CRRT to low efficiency dialysis?
This is my second step of treatment if you don't have CRRT, but I have to give the option if you have CRRT. If you don't have a CRRT, you will do what's called dialysis,
low efficiency dialysis.
Slow efficient dialysis at the least sodium, and you can use glucose 5% infusion during the session. So you can have to treat like PERT or prolonged intermittent renal replacement therapy with the least conductivity 128 or 130 and glucose 5% infusion to the patient to compensate for the rapid correction. Both of scenarios are described in how to dialyze patient with euvolemic hyponatremia. If your patient has high hypervolemic eunatremia, the scenario will differ, because once you do ultrafiltration, the sodium will increase in the patient.
Let me give my input.
Yes, sure. You are the critical care man. Yes. So let us know what's your opinion here.
You said it. what is the indication of dialysis in this patient? Even if the creatinine is increasing to 10, and what's the more emergency here? I think it is the hyponatremia, which is more emergent. This is the cause of disturbed conscious level. So what about status of urine output, which is very important in deciding the decision of dialysis? How much is urine output? If this patient is totally anoric with creatinine 10, I think dialysis is a solution, and you are to manage dialysis as you all said. By the way, Dr. Arola Osman said CRRT with you, Professor Hesham, and you agree with you. But if the patient is no normal urine output and this is increased,
you can try giving hypertonic saline.
I think for me, I will correct electrolyte disturbances first and not go to the risk of rapid correction, even if it is so low in dialysis patient or very rare. But I won't like to face.
I fully agree to the
I would leave a patient with a creatinine of 10. I don't know her general condition, and I wait to correct the sodium slowly.
Urea is not great. Urea is not that large, huge amount. It's 166.
It depends.
It depends.
It depends. It depends on her clinical status.
Unless there is no urgent indication for dialysis, you can try hypertonic saline. Take a while to increase the sodium 8 millimole per day or 10 millimole per day. You can close follow-up. But if the patient is hypervolemic, pulmonary edema, anoric, and has an end, you have to go to dialysis. It's another scenario.
Another important issue that I can see is that the increase of serum creatinine. If this increased serum creatinine over 2 to 3 days, I think this will be a very hypercatabolic man and needs dialysis. This one indication. But if it is slowly growing and we reach it, or even the usual story that we face, that we don't know the baseline of the patient. He may be a baseline of 7 or 6 or something like this. So I don't think there is urgent indication of dialysis. I will deal with hyponatremia and hypocalcemia first and go to dialysis. So if the patient is not...
My decision here, I will fight to do CRRT for this patient. First solution.
For me, I will correct the hyponatremia first. If there is no urgent indication, the classic urgent indication, including hyperkalemia, acidosis, hypercatabolic patient, anuria, or high volume overload. I think we are to correct first and go to dialysis safely after we correct, or look for dialysis after we correct.
By the way, I just admit patient 90 years old, presenting by serum creatinine 9.5 milligram per deciliter. And she responded to IV fluids, and she is completely asymptomatic, although 9.5 milligram per deciliter in a patient 90 years old female just yesterday. And today's serum creatinine is approaching to 3.5. So you are right. You have to individualize according to the status.
Okay. Dr. Arola said that CRRT, as you said, and better by CRRT, you can use a post filter to slow correct patients and infuse dextrose with the CRRT. She is managing a critical illness condition with CRRT classically, but going to dialysis. And
on the same side,
mainly yes, on the same side, D5 and CRRT to avoid much rapid correction.
There is a calculation for that on both sides. If you have a patient with hypernatremia,
this is
you increase the bags of CRRT by calculated dose of hypertonic saline. So it's a bi-direction, hyponatremia and hypernatremia during CRRT.
Yes, hypernatremia is a different issue. The problem is mainly with hyponatremia that is more difficult.
But you have to give a high dialysate sodium in CRRT.
High dialysate. Okay. Let me check. I think Dr. Ibrahim Omar, unmute yourself, please.
شكرا لحضرتك يا فندم. والله بس يعني احنا معانا مريض insist to do over clearance 4 sessions per week و maximum blood flow maximum dialysate flow وبقاله سنين طويلة ماشي بالريجيمين ده. العيان بيغسل من سنة 90 لغاية دلوقتي، يعني 34 سنة. ده أقدم مريض في السعودية، أنا يعني تابعته فترة من الزمن. مفيش في حاجة كلوزلي ريليتد للونج سرفايفل على الدياليسيس غير إن هو بيعمل أوفر كليرنس. انجلترا لما سجلت العيان عندهم ماهيش مهتة، غسل 18 سنة او عاش 18 سنة على الدياليسيس، يعني عملوا ضجة كبيرة. يعني ازاي عاش الفترة دي كلها؟ ده الراجل ده قاعد 34 سنة على الدياليسيس دلوقتي، وما عندناش اكسبلانيشن خالص ليه غير ان هو
ما
بيعمل
شاء الله يا
اوفر
ابراهيم، ما شاء الله يا
كليرنس.
ابراهيم، ما شاء
ما شاء الله.
اخته كانت بتغسل وماتت بعد 10 سنين من الدياليسيس، ولكن المريض ده
ما شاء الله.
فاقصد اقول لحضرتك يعني ممكن يبقى فعلا الاوفر كليرنس ريليتد للسرفايفل، وبالتالي ده
لا
كان ليه
لا
ا
لا
جود
لا 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 لا, لا.
كونتريبيوشن.
دي قصة تانية خالص، ما تقدرش تقول augmented dialysis can improve, prolonged session can improve, metabolic profile correction، كل ده كان improve. لكن 35 years is a record. ما انا عندي اكتر عيان كان 25 years.
لا 35 years is a record يعني congratulations.
record yes.
34.
يعني my advice don't touch this man, leave him.
بالظبط. ولا تجيب سيرته في الويبينار كمان عشان
يعني okay, Professor Hesham, Professor Walid, no more questions, no more comments. Can we close, please, Professor Walid?
yes please.
Yes, of course, of course. We enjoyed it, yeah, Dr. Hesham. We really enjoyed it, and
Thank
it's
you.
a very good opportunity for me to absorb the massive scientific information that you have.
Panoramic. It's just a panoramic.
حقيقي panoramic as usual. يعني انت عارف انا بحبك قد ايه. ربنا يخليك يا بوس.
انت اللي علمتني الدارس. ربنا يخليك.
لا ده يبقى شرف كبير قوي لما انا اكون معلمك وبتقول الكلام الكبير ده.
ربنا يخليك يا رب. اشوفكم على خير دايما ان شاء الله.
شكرا لحضراتكم، شكرا جزيلا.
شكرا.
شكرا للحلقه الممتعه دي. Thank you for this very interesting session. See me chapter meetings, and excuse me to close. See you coming Wednesday ان شاء الله.
I have to admire your effort يا دكتور ياسر. يعني انت بتلمنا كلنا حقيقي يعني. ربنا يحميك لينا يعني ويخليك.
شكرا جزيلا.
طبعا مجهود
جبار.
جبار.
جدا بوجود حضراتكم والله، ربنا الله اعلم.
مجهود جبار طبعا.
ربنا يخليك، ربنا العالي يعني. شكرا جزيلا.
شكرا جزيلا. اشوفكم على خير دايما.
تصبحوا على خير.
السلام عليكم.
السلام عليكم ورحمه
الله.